Fashion and Policy at Manchester event, Ending the Postcode Lottery, How Policymakers Can Address Health Inequalities Across the Country. I'm Dr. Rebecca Montacute, and I'm the Research Director at the Social Market Foundation, and I'll be chairing today's session. Just a few quick bits of housekeeping before we get going. So we're not expecting a fire alarm test today, so if a fire alarm happens, it is real, please respond to it, head and follow the signs out to the nearest emergency exit. The session is being live streamed, so it's on the SMF's YouTube, and also it will be being recorded for social media. If you've got any questions about that at all, please find a member of the SMF team afterwards, and they'll be happy to answer any questions on that. And please do also post on social media during. So the Social Market Foundation is at SNF Think Tank across social media platforms. And today's session is also together with Policy at Manchester, and a big thank you to them. The University of Manchester's Policy Engagement Institute, we'd like to thank them for supporting the event. You can find them on @UOM Policy. And of course, the hashtag for Lib Dem Party Conference in general is #LDConf. So I'm delighted to be joined by today's panel. So with me are Professor Arpana Verma. She's the Clinical Professor of Public Health and Epidemiology, as well as Co-Director of Policy at the University of Manchester. I also have with me Alex Kenney. She's the Head of Government and External Affairs at the British Heart Foundation, and Andrew George, MP, who is the Member of Parliament for the Liberal Democrats for St Ives. So health inequalities are widespread across the UK, and we know that in the most deprived areas, healthy life expectancy is actually 18 years lower than in least deprived. And there are also lots of inequalities, as well as between different socio-economic groups and also between ethnicities and genders. So this event will explore the policy levers needed to address those inequalities and the role of cross-government cooperation in tackling them. So without any further ado, I would like to invite Professor Arpana to start with the first remarks.
Thank you, and what a great privilege to be here speaking to you all about some of our research that we've done and are currently undertaking. With Policy at Manchester, one of the key things here at the University of Manchester that we focused on is not just trying to work out why these inequalities exist, but the fact that we can do something about these things. One of the other key things I wanted to get across is, as Becky said, that need to work intersectorally and being able to think across these intractable problems. Because if it was easy, we wouldn't be here now talking about the inequalities that have existed. So in our research, we focused on looking at how we measure inequalities and then looking at this at different geographies. Our first project was looking at this at an international level. And what we found was that those differences that we saw between nations was actually much larger when we're looking at our cities. And so for many of you, you'll know this yourselves, being there at the forefront of all of those challenges that our communities have, is that whatever indicator you look at, whether it's health or social mobility, you see bigger differences in our communities, more so than when we just look at what's happening at national level. And what we've always tried to say is data's brilliant. They indicate that something's happening, but what we want to do is really focus on getting under the data to work out what is it that's happening. One of the most powerful resources that I think you'll have are your public health departments in your local authorities, in the Office of Health Improvement and Disparities, and the UK Health Security Agency. One of the key things as public health, and wouldn't I say this, as a public health professional, is that we need to work with our communities to come up with the answers and to show that connectiveness with our communities for that compassionate response. And being able to really think through what's needed, because often we end up looking at a one-size-fits-all, and that just isn't working. I think one of the things that we found from our research is that we need to be having our communities at front and centre in telling us what's required, because they know. And I always quote one of our experts through experience who says that we're not hard to reach, it's just that we're easy to ignore, and that we do feel that we're empowered to speak up, but nobody's listening. So with all of our research, we put together a bid for a really exciting programme of work that's funded through the National Institute of Health Research, called the Health Determinants Research Collaborations. And so I'm very proud to be part of the Manchester HDRC, but it's a whole community of 30 other HDRCs. And with Hashim from Policy at Manchester, we're working very closely with our City Council to think about how we have our communities leading research, creating the agenda, and being able to influence what's happening in terms of local policy. Because from the work that we've done looking at policy impact from the past, it's these hyper-local policies that are actually going to make the difference. So whether we're talking about looking at health literacy and also that link up in that poverty vicious cycle, that we need to have the ability to think through the digital, the financial and the health literacy to work out what's needed in our communities and think about what makes those intractable inequalities something that we could come together, work across all our disciplines to try to get rid of inequalities. Thank you.
Great, thank you so much. And Alex, could you tell us a bit about the role that health inequalities play specifically in the nation's cardiovascular health, and also a bit about how that differs across different regions as well?
Yeah, absolutely. Hi, everybody. So I should say, reducing health inequalities is central to BHF's new strategy, and for good reason. Cardiovascular disease is a disease of inequality. It's associated with and driven by inequality. And we know those inequalities exist across the cardiac pathway. So from your risk of developing cardiovascular disease, accessing cardiac care, and to your quality and length of life. So I'm going to paint a bit of a picture with some statistics, so bear with me. So starting with risk factors, we know that in England, obesity prevalence is 15 percentage points higher in the most deprived areas. In Scotland, smoking prevalence is almost 5 times higher in the most deprived quintile. And in England, cuts to the public health grant have hit the most deprived areas hardest, which impacts the ability of services like smoking cessation and weight management. When it comes to care, we know that people living in more deprived areas are less likely to be able to access care, less likely to reach treatment targets, and less able to manage their conditions as well. So barriers like prescription charges, needing time off for work, this contributes to this issue. Additionally, GPs in more deprived areas often face higher caseloads, which makes it difficult to monitor and manage clinical risk. And then on outcomes, cardiovascular disease is the single biggest contributing disease to the difference in life expectancy between richest and poorest in the UK. So in 2022, the rate of premature death from cardiovascular disease reached its highest level in over a decade. But what's concerning is that this rate was 2.5 times higher in the most deprived areas. And this was a pattern across the UK. so all the 4 nations. Also, more deprived communities in the UK have a higher rate of death from cardiac arrest, but conversely often have fewer defibrillators. So it's this really unfair disadvantage. Deprivation is just one lens of inequality, of course, and Becky, you mentioned sort of sex and ethnicity, and earlier this year we published a report called Bridging Hearts, which looked at these lenses, and some key findings included rates of high blood pressure are notably higher amongst people from Black, African, Caribbean and Pakistani backgrounds. Men are generally less likely to engage in primary care. We found that over a 10-year period, more than 8,000 women's lives were needlessly lost to heart attack and stroke in England and Wales because they didn't receive the same care as men. And many ethnic minority groups are severely underrepresented in clinical research, which limits our understanding of how ethnicity impacts outcomes. So it's quite a bleak picture, but what can policymakers do to address this? I think firstly, it's really important that we meet people where they are. The new neighbourhood health model offers some promise, but they do need to be truly community-led. Secondly, they need to be resourced properly. So we see so many great pilot programmes, sort of community blood pressure checks, for example, but they face funding shortfalls and workforce challenges, so they can't deliver on their full potential. And third, we need to see a cross-government approach to inequalities. So the wider determinants of health, like poor housing, air pollution, they sit beyond the remit of Department of Health, so other departments have to play a role. And what are the role of charities? Obviously, I would say that civil society should be a key partner for government in its efforts to address health inequalities, but I do think this is true. We bring a wealth of expertise and support that's often underutilised and often misused. And what I mean by that is too often we're brought in quite last minute to support or promote policies that we've not been actively involved in developing. And this feels lip service. How can we be certain that it's going to treat the communities that we serve, especially those most in need? Research funded primarily, but we do and can support government in many other ways. So we have a fantastic health analytics function, so who monitor population health data, and we can help policymakers understand how and where inequality is felt the hardest. We have a large patient network that we can survey and best understand what patient need. We have strong links to the health service at both national and regional levels, which means we can share practice, and crucially, we hold government to account on our various NHS boards. So it's not all bleak. There are real opportunities in this parliament to make some difference if we can work together and hold government to account on these. So from Diagnosis Connect, the men's health strategy, the 10-year health plan, and we can discuss more in the Q&A.
Thanks very much. And Andrew, I myself am from the Southwest, and I always feel like the Southwest gets somewhat left out in some of the chats about wider regional inequalities, and maybe not always considered in quite the same way as, say, the north of England. I'm interested in what you feel the impact of persistent health inequalities are in the Southwest, and particularly in your own constituency. What kind of issues have you been seeing?
Well, thank you. Thanks for inviting me. And just to let you know that St Ives is St Ives in Cornwall, which is just if you cross the Tamar from England and arrive in Cornwall, it's the far end. So I'm the bottom left-hand corner. So it's West Cornwall and the Isles of Scilly. And yeah, I'll come on to the issue of the geography of the area, the geographical impact on health inequalities in a moment. Just to really give you a little bit of background, I'm also a member of the Health Select Committee, and we're undertaking a large number of inquiries, including looking at the government's three shifts, which we welcome. That approach, we think it's common sense and makes sense. I could spend 5 minutes castigating the previous Tory government. I'd love to do that, but that'd probably be a waste of time. So I'll just concentrate on the positives of what we can do. In relation to the Health Select Committee, we've just this last week produced another report, this one on Black maternal health, which has indicated very significant inequalities with regard to, I mean, not necessarily postcode lottery, that rather hackney phrase, but in relation to inequalities, certainly within that service, and highlighted a large number of factors which are working to give black women especially poor outcomes when it comes to maternal health matters, and of course we have other inquiries coming up as well. I mean, I could trot out, but I haven't got them with me anyway. Statistics which obviously compare, along. I think usually it's on a railway line or something, with the life expectancy from one end to another. And I think we all know that you in the audience and certainly other panel members are well aware of how those outcomes vary very significantly. I mean, in terms of the concept of postcode lottery, my personal view is that there's nothing wrong with having the opportunity for local health economies to vary beyond, if you like, a national standard of health outcome. If they wish to improve or vary or put a greater emphasis in certain areas rather than others, but making sure that we have established a national baseline, I think is really very important. Obviously, as a party, we're very much in favour of strong devolution and strong local creativity as far as these matters are concerned. But it shouldn't be creativity to cut and undermine services. So obviously, we do need to have that baseline. With regard to the geographical issues which you mentioned, one of the matters which certainly affects us because we're at the end of a very long, thin peninsula down at West Cornwall, Land's End, the Lizard Peninsula on the Isles of Scilly, is that, of course, if we're talking about the emergency services or the need for urgent care, unlike, say, for example, Oxfordshire or many other parts of the United Kingdom, we can't call on or send patients when our services are overloaded to either the north, the south, or the west, because that's rather wet in those areas, and we can't. There won't be anything there. And the nearest for West Cornwall is for some constituents 90 miles to the east to Plymouth. Or from the Isles of Scilly, over 100 miles as well. So very, very difficult to make sure that you actually have a decent range of services available to people in need of urgent attention, strokes and heart attacks and other conditions that need to have very, very quick response, other types of trauma. Then obviously we need to have those facilities in place. So our emergency department is often overclocked with 20, 30 ambulances queuing and the service overrun. So there are that on top of many other reasons we do struggle geographically with maintaining the same standards that other parts of the country take for granted. Thank you.
Thank you so much to the panel for all of those initial contributions. I'm just going to ask a question before I open it out to the audience. So we've heard there a mix of some of the issues that come quite early on in terms of wider public health and prevention. And then we've also heard some of the issues at the acute end once people are going to try to access care, what some of those barriers can be. I just wanted to ask everyone, if you were going to say to policymakers which of those two ends you think there should be the greatest focus, or where would you most like to see efforts directed, where would you personally put it at the moment? So if I start with Alex and go across.
It's a very tough question. Obviously the acute is very acute, but I think often that's where focus is already given. I think personally, I would focus on the prevention. It takes a lot longer to see the fruition, but it will have the longer term better impact. So I would start with kind of public health and prevention.
And Arpana?
It won't come as a shock to you, prevention. And I think one of the key things that we that it ends up being an acute versus prevention. And what we need to do is change the dialogue, I think, so that we're thinking about how we address that need to really invest in our health service becoming a well-being service through these prevention, without taking away the fact that we still need to deal with people with acute heart attacks and strokes at the same time as thinking about the reasons why they've had a heart attack and a stroke. And so being able to really change that dialogue so we're not in competition. And I think, as Alex said, that often it looks like it's taking a while to get preventative actions to pay the dividends, but it can actually be quite quick, especially when we're thinking about the wider determinants. So things like air pollution causing acute episodes of cardiovascular and respiratory disease is something that we can all do something about really quickly.
And I guess as we come to you, Andrew, do you think it's easy for policymakers to think about both of those ends in the way that we wish that they would have a focus on both sides? Do you think it's easier to think about the acute issues?
Yeah, so I mean, to a certain extent, a lot of politics is platitude, isn't it? You know, if you take the three shifts, I mean, no one is arguing for the contrary. In other words, no one's saying that we should shift from prevention to illness, you know, or from digital to analog, etc. So yes, obviously, you know, prevention is far better than people falling ill. You know, let's prevent. I mean, I think that's been it's been a kind of political mantra going back all my time in politics. So the question really is, how do we get to that point? How do we actually make that shift so that we get on top of illness to the extent that we can now start you know, putting a sufficient emphasis on prevention. I mean, if you've got 30 ambulances queued outside your emergency department, and you know, half of the people inside it are actually in corridors, you know, on trolleys, or sitting in chairs, and they shouldn't be. They'd be lying flat. You know, you can't put your attention into prevention, can you? The other issue is just in relation to geography. I suppose it's sort of partly kind of connected in a way. That in an area like ours, if you're trying to kind of address matters of prevention, sometimes, particularly amongst the older population, disabled population, when they're offered appointments at some locations, they'll say it's too far away. I think I'll just one out. So they don't attend, and also when they don't have the choices either. So if you're living in the middle of the country, you might be able to say, well, I don't want to go there, but I can go, you know, 50 miles down the road in the opposite direction. You can't do that. It's either, you know, at our end, it's you know, it's either 100 miles or 200 miles or whatever, and then you're talking about overnight stays. And if you've got to stay overnight, then how is your family going to come visit you? And I think, you know, I can't be bothered. I'll take the risk and not go for that checkup. And that often happens, and it's a narrative which we pick up quite often.
Thank you very much. So just before I ask any questions, before I let you guys ask any questions, I have a quick question for everyone in the audience for a bit of fun, which is about your own health behaviours. Has anyone been brave enough this morning to take a swim in the sea? Wow, that's quite a few. Well done, guys. I could not have done that myself, so I'm very impressed. Okay, any questions from the audience? And just to say that we don't have a roaming mic, so please speak up as loudly as you can. Yes, just at the back. Yep.
Hi, hello, you can hear me. My name is Larissa Lockwood from Global Action Plan, and I was very pleased to hear the panel mention air pollution, because air pollution is it's the number one environmental determinant of health, and is both a social and environmental justice issue. So it's often the poorest in society who live in the most polluted areas, and yet it's not the people causing the pollution. They're not car owners, they don't have a wood burning stove, And how for these agencies to do something about it? They're not able to just move house or switch from a gas to electric cooker. So I'd be interested to hear the panel's thoughts on what you think needs to be done to tackle air pollution, and whether and how the Lib Dems could be campaigning on air pollution as a health prevention and a health inequalities issue.
And just on that, obviously, efforts to tackle air pollution tend to be quite politically divisive. So I'd also be interested in views from the panel of your thoughts on how politicians can navigate that in part as well, and if you feel like they're doing enough at the moment. So if I start with Andrew and come across.
Thank you. A very difficult one. I mean, normally politicians will respond by setting targets and then putting investment in those, or trying to shift the balance of tax and benefits to kind of shift like encouragement towards electric cars, etc. And similarly with household heating systems and obviously industrial sort of energy sources, etc. Those are all matters which the political classes tend to put their emphasis on. So certainly, I mean, we have we as a party have very ambitious targets with regard to cutting air pollution. It has to start with the application of a stick, the target, and failing to meet target, results in fines and humiliation for local authorities, etc. So it's you can kind of down with shame, I suppose, to a certain extent. But you do need to address those issues. I know I'm talking in generality here. I'm not giving you specifics, but certainly, all of those are measures which we would generally apply.
Arpana?
Thank you. Could I encourage you all to read the Chief Medical Officer's report, which has a really great chapter on active travel. I have a stake in this because it's my marvellous PhD student who co-wrote it. And I think one of the key things that you said is absolutely core to all of the research that we've been doing. Public health is a social justice issue, and that inability to control your environment in the same way as those people that have the economic ability to be able to do that is absolutely central to a lot of the work that we've been doing. And I think having active travel solutions is core to any policy that we make for urban and rural. And I was listening to, I think it was Farming Today, about the issues of travel and active travel also in our rural communities. All of my research has mostly focused on cities, including coastal cities, but where you've got that ability where the science can actually inform evidence is in air pollution, whether it's household or from traffic. What we've got is a lot of great researchers that can give us the solutions. And I think that CMO report is really fundamental to making that difference.
Alex?
Thank you. And I would really echo what Andrew said about targets. So British Heart Foundation has done lots of research, or funded lots of research into air pollution and the impact it has on your cardiovascular system, and it is really significant, which is why 5 years ago we were campaigning with other members of the Healthy Air Coalition, and I know some of you here already, to kind of influence the Environment Act, and we were successful in that we've now successfully made it so that air pollution is now a health issue, not just a sort of a climate change issue. But sadly, we weren't successful in getting the government to commit to WHO limits for PM2.5, which is the fine particulate matter. Positively, the government has committed in its 10-year plan to relook at PM2.5 targets. So I think there also needs to be some more support for local authorities to then monitor those levels of air pollution. Otherwise, we're just not, again, it comes back to the data and knowing kind of what is happening. So yeah, that would be where I would want us to focus.
Yes.
Yeah, Dr. Verma, I'm from Cardiff. I'm a councillor there. I'm also standing for the Senate elections next year. And I've been campaigning for some time about more focus on addressing health inequalities. I think it's a vital topic. But from the research I've done, I haven't looked at it recently, but it seems to me that we've known about these disparities for some time, about differences in life expectancy, healthy life expectancy between deprived communities and better off communities. But we've not really managed to shift the dial over a long period of time. And just, what do we need to do differently? Why is it that what we've been doing hasn't really changed that? Are there more things that we need to be doing from a policy perspective that can help to try and sort of close those gaps? I mean, my own thoughts are that we maybe need to look at things like sort of working with local communities on things like lifestyle choices. Now, some of the things they can't help in deprived communities we're hearing about, but some things maybe about the choices they're individually making, bad diet, etc., smoking, etc., and whether somehow we need to sort of be a lot more interventionist, I suppose, in working with communities. I wonder what you thought of that. And the other thing I'd just like to ask about is whether anybody has any thoughts about maybe the impact of, say, ultra-processed foods, for instance, in driving obesity, because that's basically come about because the food industry isn't that regulated. It looks for how can it make products more desirable and want to buy more and more of them, etc., to get its profit margins up. And it drives us to foods that maybe contain things that are harmful to us. And there does seem to be increasing evidence that ultra-processed foods are linked with increased disease prevalence, driving obesity, etc. But there's not very clear evidence as to how exactly they're causing that, and whether it's all ultra-processed foods or whether it's some or whatever. But one of the
Sorry, I'll just stop you there just to give them a chance to answer. So
can I just do one last thing? One issue is that often ultra-processed foods are made because they're actually cheaper, and that's something that then means that maybe more deprived communities are more reliant on them.
yeah, thanks so much. So Arpana, the two questions of should we be being potentially more interventionist about lifestyle changes, and then also the question of ultra-processed foods.
Thank you. So with the interventionist, that ability for us to get into a way of talking to our communities that makes sense to them, because I think we're so built into, we've got these 500 evidence-based interventions, we're going to nudge you, we're going to do this. But fundamentally, it's down to the individual's way of being able to process all that information and moving away from that blame culture so that we're thinking about those wider determinants. As Alex said, it's these other things that we've known about for decades that are driving our inequalities, and yet we're spending more and more on being able to think about what isn't necessarily going to help that individual in that community. And I think your example of ultra-processed foods is exactly right, because it's inherent to all sorts of different aspects like health literacy and the ability to afford high quality food. And I know that there's been apps produced and loads of other digital technologies. And again, I'll just quote one of our mums who said, I can't actually afford the food that I need. It's that heat or eat issue, let alone you showing me this marvelous app. And I think that poverty cycle and us getting to the bottom of what's driving unhealthy choices, and that mantra of making the healthy choice the easy choice, because I think that's where we failed. We've not worked across departments to make the healthy choice the easy choice.
And Andrew, what are your thoughts on this?
I think that again we need to look at prevention. I'm in favour of prevention. I'm also very much in favour of the pejoratively termed nanny state, actually. I was around when we smoking in public places. I mean, a lot of people were saying it was taking people's freedoms away, and it was a disgraceful act amongst kind of libertarians and so on. Yeah, no one would go back now. Similarly, you know, wearing seatbelts, you know, when that was made compulsory, again, an argument about, you know, freedom. Who would go back? No one would. So, I mean, we can do the same with food. I see no reason and processed food. I think it's possible. I'm not saying I'm going to design something which says, you know, sugar, fat, salt, you know, levels should be limited to this level. I'm not going to prescribe that myself right now, but I think it is possible for people more expert than I to come up with a food strategy which would actually be more kind of on my kind of nanny state approach, and sort of you know, curb things or heavily tax things that go beyond what is wise for anyone to consume. The way in which it's retailed, it's very clear that in spite of, you know, kind of promises from both retailers and manufacturers that they're doing their best, I mean, they really aren't. You know, it's very cosmetic kind of changes, and it's all about their public relations, really, rather than actually doing anything substantial. So that's that. I mean, it's quite interesting that we're about to launch in the Health Select Committee an inquiry into food and the food industry and weight and health. I can't say too much because it would be disclosing too much about the internal discussions within the Health Select Committee, but we were quite divided about whether we should be looking at preventative actions or treatments such as Nanjaro and bariatric surgery and so on, as concentrating on that side rather than actually trying to prevent this happening in the first place, rather than treating people once they have, you know, they kind of create unhealthy lifestyles for themselves.
And Alex?
Yeah, would echo kind of what the panel has already said. But I think the question, even though it's two parts of the question, I think is kind of the same answer. And I think we do need to be much more interventionist. And I think one of the concerns that we've had in the public health sector is that government often gets cold feet. And we've seen that with tobacco, we've seen that with food industry, and I think there is pressure from those industries to weaken or delay. You know, we've seen it with the junk food advertising ban, that's been delayed. And I think thank you. And I think there does need to be an element of boldness and braveness from government. And I think for us at British Heart Foundation, it's not necessarily the ultra processedness of food, but actually, you know, levels of salt in things that actually people don't realise is in products, so like bread and things like this. Salt is a really big driver of high blood pressure, linked to half of heart attack and stroke in the UK, and not many people, you know, are even aware of that. So absolutely, I think we need our politicians to be brave, and I'm very pleased that Andrew is a fan of the nanny state, quote unquote.
Yeah.
Oh, thank you. I'm a GP, and I'm so enthused to hear the whole panel get behind the agenda for prevention and interventionism as well, and the focus on communities and deprived communities in particular. You've all referenced the 10-year plan, which is predicated on bringing focus to neighbourhood-led care. Well, I might suggest in the current economic climate, we've got 6,331 neighbourhood health centres. They're called GP surgeries. We see 1.5 million patients every day. Take A&E by comparison, they see 230,000. But I'm worried as a GP that the 10-year plan is all about debt share rearrangements and emperor's new clothes. As a GP, I've got no idea what a single or a multi-neighbourhood provider contract is meant to be. So I guess it's a plea. When the economics are bleak and tough, when there is no new money left in the kitty, we need to keep it simple. We've got GP unemployment in the UK right now. Practices have got such little resource, we can't increase our teams, even if we wanted to. So there's no space to house them. So we can speak about prevention, and as a preventer, I can't provide to my patients what they need. So I'm keen to hear your thoughts about what those solutions might be.
Andrew, should we start with you there? Give you all the toughest ones first.
Well, thank you. You're very kind. Yeah, I mean, the difficulty is, as far as I can see, I mean, everything you say is absolutely correct, and there's a lot of rather vague and woolly thinking and terminology at present in terms of the neighbourhood hubs. It's a nice and woolly concept, and it's something which we can all kind of broadly agree with. But I think that it would have to be rolled out differently in different scenarios, given what's already on the ground. Otherwise, it's going to be massively destructive. So it's better to build on what's already there rather than coming in with something kind of very expensively to kind of overlay it in spite of everything else. So my concern about the shift from hospital to community is the one that kind of worries me most. And when I've been speaking to, for example, the Royal College of Emergency Medicine, they're saying that actually what they need to have beds that they can admit patients to, rather than having them in corridors and so on. And so they actually need to see that we need to front load that shift by enabling our hospitals breathing space and avoiding the 99% bed occupancy kind of circumstances which affects their ability to provide care. And then at the same time, front load primary and community services so that they can start building the capacity to take earlier discharge from hospital, and also to build prevention into the service. How that looks on the ground really is going to vary, as I say, from place to place. But the government does need to, over a 4 or 5 year period, during this transition, it's going to cost them more money. It's going to be a bulge in money while they invest for the transition before you settle into the new methodology.
Go back to you on that point, because
Sorry,
in our patch we reduced admissions by 40%, but the hospital just filled the beds with different people in terms of frailty, so over 65s and frailty, but the flow through the trust remained the same. So they didn't see any difference in discharges or admissions. They just filled the beds with different people. So we can work as hard as we can in the community, but if there's no change to how the acute throughput goes through the hospital, we don't make any difference. The problem comes in NHS management, and it feels like we've got a David and Goliath problem.
Sorry, Andrew, I won't come back to you now, but you've got get a chance at the end to respond. Alex?
I think redesigning kind of primary care is going to be really difficult and also really disruptive. So I think looking at solutions in sort of community pharmacy and sort of share, you guys are so at capacity already. So it's about how can we better share that load and sort of deliver some of those services sort of in the community cardiac rehab, for example. You guys aren't expected to deliver that, but actually how can you work with colleagues across your patch? And I don't necessarily have the answers to that, but I think there does need to be some thinking there from government in the design of the delivery of the 10-year plan.
Arpana?
Thank you, and a great question, because primary care is key. It's just where it has to be at in terms of that ability to work with your colleagues across the different disciplines for our people in our communities, and just thinking of the opportunities for making every contact count. You've got it you're in the neighbourhoods, as you say, and you've got that knowledge of not just that person, why they're walking in through that front door, but all the other things that are affecting why they've come then and not 10 days ago, versus probably you'll know who's going to benefit, because you'll know all those other things that are having an impact on why they don't take the drugs that they've been prescribed or the interventions. And fundamentally, being able to shore up primary care is absolutely there, in my opinion, to building the health of our populations and being able to listen and feed that back to policy, and to be able to work closely with public health the acute sector, our voluntary faith and community services, that hub that you form is unique. And from looking at other health systems, it really is something we should be proud of, and something we really need to make sure that we are doing what we can to ensure that we don't lose primary care.
Thank you so much, and apologies for cutting you off there, because it is really useful to be able to get that insight on the ground. I just want to make sure we get as many questions in as possible. So we're going to have one final question, but if the speakers could then also do a combination of answering that and also giving their general final closing thoughts as well. Yeah.
Thank you. I'm from Cancer Research UK, and just to reinforce another stat, you're 60% more likely to die from cancer in the private community than anywhere else. I wanted to focus on a little bit of the how. So, Andrew, one thing Liberal Democrat peers can do is support the tobacco and vapes bill when it comes back to the boards after recess, hopefully, because that will make a significant difference in preventing people from ever starting smoking. But I agree with the panel's reflections that we need to be bold and ambitious. So I'm interested in what the panel would like to see in the forthcoming budget that would help address this postcode lottery. We have one suggestion. Introduce a tobacco levy on tobacco manufacturers' profits that could be then used to target areas of greatest need to help people quit. But you will have others. Thank you.
What a great final question to end on. So what would you like to see in the upcoming budget, and also just any final reflections as well? So if I start with you, Alex.
Yeah, sure, completely agree on the tobacco bill, unsurprisingly. It's a good question. I think one of the things that could be transformative for tackling inequalities is the upcoming review of the Carr-Hill formula. We've long known that this does not serve the communities that it needs to. So we're quite interested in seeing kind of how that transpires, and potentially the budget could look to that. And Becky, to your point, my final reflection, I think actually we also need more of a top-down approach on inequalities. We've obviously just seen that the Prime Minister's mission board has been scrapped. These missions have gone awry. But actually, I think we're only, as I said before, because the determinants of health sit across government, I think the only way you're going to tackle it is if it comes from the Prime Minister and the cabinet down.
Arpana.
Thank you. So on your point about cancer, really feeds into the things that we've been doing in Greater Manchester. And one of the key things is we should not ever be seeing the first diagnosis of cancer in an A&E department. And that inequality is really prevalent. And so that, to me, shows that failure of the system. When we look at who gets to our superb tertiary services for advanced radiotherapy and chemotherapy, it's not necessarily the people that need it the most. And so I think one of the key things is that shoring up of primary care and public health. And we have a food strategy. Not sure where it is. It's still available on the website, and a lot of these different opportunities, like tobacco and vaping, like the ability to influence how we deal with big business, is fundamentally down to how we are allowing the advertising of some of these products completely unlicensed to our most vulnerable populations, including women of childbearing age and children, and then our vulnerable communities as such. One of the key things that I wanted also to say is we believe that inequalities are driven by that discrepancy of funding for research. And good science, as Alex said just now, who's actually taking part in the studies that form that evidence base? So in Greater Manchester, I co-lead our Inclusive Research Oversight Board, where we're actually trying to drive people with the protected characteristics into our science and into communicating with us, and being able to think about where the funding for good science goes. And that means linking up with pharma and other businesses to be able to make that step change, to be able to say this is now a social justice issue, that we have got data that may not actually meet the needs of our communities because the wrong people have formed those data. So I'd be very keen to explore that with Cancer Research UK. Thank you.
Great.
Thank you. Yeah, so first of all, I'm sure that the Liberal Democrat Lords will be supporting the tobacco and vapes bill. I don't think any that don't will have to be answerable to their whips, etc. In terms of the budget, I'm not sidestepping it, but one of the things where I've been kind of looking at the widening inequalities, which results in the widening disparities in health, is the way in which the tax system operates and the numbers of tax loopholes that exist. For example, in Cornwall, £500 million of taxpayers' money has gone into the pockets of second homeowners through a system whereby a second homeowner flips to describe their property as a holiday let, applies to small business rate relief, and then there's nothing, and that has to be subsidised by the Treasury to the local authority to fill the gap. And that £500 million over 10 years. If you've spent that on health disparities, that would really kind of address things. And the thing is, if you just take that one example, I just think we're turning a blind eye to far too much in the system which favours the wealthy. I mean, apparently we're not supposed to say that we're in favour of wealth taxes, but I mean, I think it's just a generalised term, but I do think we need to look at the way in which the tax system works in order to really strongly combat the widening inequality in our society. So I think that's an area of work which the party and politicians should be shying away from because they fear, wealthy barons, running right-wing newspapers and so on. The other, in terms of going forward, there are 2 points I've made. One, we haven't really heard much for kind of early years. I think that certainly in my constituency, look around the country as a whole, I just think we're letting our children down. I think we're giving them an appalling start in life. I think their opportunities are not even what they were from me in my generation. I think we need to be looking much harder at making sure that our children get the best possible start in life, both in terms of their health, of course, but in terms of their opportunities, education, special educational needs, especially, and that needs to be addressed during early years, not wait until they get to school. It should be kind of really backing young people. The other thing, which I'm sure the other panelists would be pleased to hear me say, and that is that I have a massive fear going forward, looking at the way politics is going, both here and across the Atlantic, that we might be turning our back on evidence-based policy making. I really think that we want to be standing our ground to make sure that policymakers are informed on the best available science and evidence, and I'm extremely fearful of just the general tenor, both of the political discourse and also what appears to be happening over there, and often things that happen over there come over here, and there's signs that they are. Thank you.
Great, a big call for support for the importance of evidence-based policy seems like the perfect place to end on. A huge thank you to our panel and for all of the questions from the audience as well. Just two quick final bits. So first is a little bit of a plug for the Social Market Foundation. We have a fantastic newsletter every week called Wonk Week. We go through all of the major reports that people are putting out in Westminster so you don't have to, and give a summary straight into your inbox. Please do pop onto the Social Market Foundation's website and there's a link there to sign up. And also to say, I'm sure you'll all be glad to know that there is lunch available in the corridor outside. So please do help yourself. It will be there until 2:30. And thank you so much again for coming along.